behavioral medicine, health psychology, integrative oncology comes from the medical world, and the model of clinical trials that's come from the medical world, which actually is largely drug trials. But that's how our discipline has developed, is trying to take those methods that they came up with in medical science and adapt them and somehow apply them.
Sorry, I'm being the camera person.
Well, good luck. Somehow
I'm trying to
apply them,
record,
to
Linda.
behavioral trials. And I guess just to make a distinction, I mean, what is a behavioral trial anyway, right? It's a very broad concept, and we'll talk more about it. But any trial where the intervention itself targets a behavior or involves a behavior change, or where the outcomes are a behavior. So if you're trying to decrease smoking cessation, right? That's a behavior. So you're trying to change someone's behavior, or the intervention itself is a behavior. So you're trying to train them to do yoga or meditation, right? Or you're using, well, acupuncture is an integrative oncology, is a behavioral. Well, we can talk about those distinctions, right? What makes something what it is, yeah.
And if you give the laptop a little behind, it can cover this.
Oh, sure.
So,
What, Linda and the slides? Okay.
Well, people are going to have the slides so they can follow along, right? Because the slides are on D2L. It'd be nice to get it all in one place. All right, good on you. So why are clinical trials so important? Why is everybody always talking about RCTs, clinical trials, like what's the big deal, right? So to understand that, we have to understand the hierarchy of levels of evidence. And, not all evidence is created equal, right? So some evidence is considered more convincing, or more, people always say, oh, it's been proven. Nothing is ever proven in science, right? It's only disproven. You can't, so people say this trial proves that whatever diet is, causes cancer or prevents cancer. That's the wrong way of thinking about it, right? There's only more or less conclusive evidence, and it's body of evidence. No one study doesn't really tell you much of anything. And then we'll talk about traditional medical trials. Again, what are the definitions of clinical trials? What are the phases of clinical trials? And then and again, the randomized controlled trial, which is the gold standard. And then, at the end, we'll begin to talk about mapping all that on. You have to have this background knowledge to understand how it maps onto the behavioral world. So what is a clinical trial? So the WHO definition, and sort of the key elements are bolded. So it's a research study. It prospectively assigns, which means that it assigns people over time before an intervention to one or more health-related interventions. So an intervention can be a medication, it can be a training program, it can be a treatment of some kind, and evaluates the effects on some kind of health outcome, right? So this can range from survival, disease-free survival, symptoms, side effects, symptom reduction, quality of life, any kind of outcome. So you look at NIH and see where these things align. Again, it's human subjects, right? So we're focusing on humans here. Again, there's this prospective assignment. So group assignment happens before the intervention. Again, there's one or more interventions, which may include placebo or other control conditions, and we'll talk about this, what are controls, and evaluates the effect of the interventions on health-related biomedical or behavioral outcomes. So NIH incorporates the behavioral bit in there as an outcome. Okay, so the key features of a clinical trial is that it's a research study with prospective assignment. Does everyone know what that means? And there's an intervention. So it doesn't mean that they're randomly assigned, it just means that they are allocated in some way, or they are part of different groups. And they're followed up over time to see what the effect of an intervention is. So that's what a clinical trial is. Does that make sense? Got the key elements there? Okay, so now I have a video. This one's kind of boring, but it's better than hearing me, I think, all the time. So, why are clinical trials important? Why is everyone always talking about them? So to understand that, we have to understand levels of evidence and how different types of study designs are considered to be stronger or less strongly conclusive around our research questions. So we'll watch this and then we can talk about it a little bit. This works.
Researching levels of evidence. What does it mean? It's a system to classify the level of scientific rigor and quality. One common system is the Bandelier levels of evidence. Bandelier is made up of 5 levels, where 5 is the weakest and 1 is the strongest. The system ranks study designs according to their internal validity or degree to which they are not susceptible to bias. What is bias? An influence occurring at any stage of the research process, which distorts the findings. For example, sample bias or interview bias. Level 1. Level 1, strong evidence from at least one published systematic review of multiple well-designed, randomized controlled trials. Level 2. Level 2 is strong evidence from at least one published, properly designed, randomized controlled trial of appropriate size and clinical setting. Level 3. Level 3, evidence from published, well-designed trials without randomization, single group, pre-post cohort, time series, or matched case-controlled studies. Level 4. Level 4, evidence from well-designed, non-experimental studies from more than one centre or research group. Level 5. Level 5, opinions of respected authorities based on clinical evidence, descriptive studies or reports of expert consensus committees. Or just briefly. 5, opinions based on evidence. 4, non-experimental studies. 3, non-randomised trials or single group, pre-post, cohort, time series or matched case-controlled studies.
Who understands that, anyone?
2, randomised controlled trials. And 1, systematic reviews. Weakest, 5. Strongest, 1. For more, visit the Wellington Medical and Health Sciences Library, University of Otago.
Okay, so I've got another slide here, if I can get to it. Oops. With a similar pyramid. So there's more than one way of classifying this. They're all getting at the same thing. Okay, so the worst evidence, the weakest level of evidence is what your patients tell you, unfortunately, right? So anecdotal, case reports, clinical acumen is not considered for much in the world of science. Blah, doesn't mean anything, right? And the strongest level of evidence, so here it breaks it down to above the line is syntheses, okay, so more than one study, and below the line is individual studies, so subject level. And at the top of that list is the randomized controlled trial, right? So everybody thinks, well, I better do an RCT because it's the strongest level of evidence. But that's not always the appropriate research design for your research question. And in this one, it breaks down this really, I think, confusing terminology about prospective cohorts, retrospective cohorts, case controls, like what does all that mean, right? These are largely epidemiological research methods that we may not learn in the behavioral sciences as much. The types of studies we often do more commonly would be the pre-post single group intervention design. That's where you have your program that you want to study, so maybe it's an exercise intervention. You have people fill out questionnaires before, they do the program, they fill them out after. That's your single group pre-post. You can make that a stronger design by having what would be called a controlled clinical study, the purple bar. So we have a comparison group of similar people who didn't do the intervention or did a different intervention, and you give them the same questionnaires at the same time points. That's stronger than just these cohort studies, which is just sort of following along groups of people that aren't matched or chosen for any particular reason. So when we look at how it's called evidence-based medicine develops, it's using this framework of levels of evidence. So beyond the individual studies, then the highest level is systematic reviews or meta-analyses, which are studies of studies. And you can even do that for qualitative research, which is called metasynthesis. Now they're starting to do. And qualitative research would sort of fall under the case report, case series sort of bit. But really, when you're developing an intervention, you actually have to start at the bottom and work your way up, right? It makes no sense to jump in and do a randomized controlled trial when you haven't even done any pre-post work on your intervention, or you haven't done any case series or qualitative work or talked to patients about what they need, right? So it doesn't mean your study's not good if it's, you know, using those different methodologies. It's often necessary to build the pyramid, right? You don't just put the top on the pyramid because it's got nothing to sit on, you know? So every intervention or every area has its own pyramid, right? And you're stacking the blocks up, and you really shouldn't be putting on the top block until you've got the groundwork. And that's a problem in a lot of behavioral research too, is that people have some intervention that they've just come up with off the top of their head, right? They think, oh, I want to teach people yoga or whatever it is, and they say, okay, let's give them an 8-week. Well, why 8-week? Why the postures that you've chosen? Like, why? But they just come up with a program and all of a sudden do randomized controlled trial and show efficacy, and so therefore no one goes back and questions, well, why is that the intervention? I know maybe we know this one works, but wouldn't something else work too? And what's the rationale? Like, is like the questions that Karsh has about dose and things like that. So any other thoughts about the levels of evidence? Has everyone seen this before?
I'm thinking about reviews and how a lot of reviews don't necessarily include all really high quality studies, and a lot of
Like non-systematic reviews?
well, even like sometimes the word seems to be misused. Like sometimes people even call things reviews, and people just assume because it's a review, it's automatically good.
Systematic. So there's also different quality levels of reviews, right? So there's Cochrane reviews, there's systematic reviews, there's narrative reviews. So you can write a review and just pick and choose the papers you want to include that support the point you want to make, right? So then it's not capturing everything. You know, you'll see lots of those, right? So people can use reviews as ways to support an opinion they have, but they're not necessarily, you know, accurately scanning all the research, right? So that's why there's all these guidelines. So within each of these types of research, there's guidelines. Like if people know Consort, Consort's the guidelines for publishing randomized controlled trials, and there's PRISMA. PRISMA is the guidelines for systematic reviews and meta-analyses, right? So there's, even within each of these levels, there's better and worse ways to do it, right? Different methods. Any other thoughts? Okay, so let's go into the types of clinical trials. I got another video. Yeah, so if we go up back to our pyramid.
Yeah. So can I just say one point
Yeah.
here? It might just show up in one of your next slides, but in the randomized controlled trials, so they also had quasi-experimental studies, which are trials but where people are not randomized to either.
So that would be under controlled clinical studies?
It's between randomized controlled trial and controlled clinical, somewhere.
Yeah.
It could be controlled,
Yeah, so there's lots of different designs, and this pyramid is actually slightly different than the one in the video, right? And so you can find yourselves all sorts of different pyramids that will include more or less detail about the studies that fall into each category.
So I have a question based on that. What would be the difference between quasi-experimental and a controlled? Like what distinguishes quasi-experimental specifically from controlled?
Well, she also used the terminology in the video experimental versus non-experimental, right? So anything that's real-life observational is non-experimental, and experimental in this context is anything where you're intervening, right? Where you're where you're assigning people to an intervention is experimental, even if it's not randomized or even two groups.
So for ethical reasons, you might not be able to randomize them, but still.
Right. But
it still would be controlled.
Control,
It would still be a controlled clinical trial.
Right.
I think that's one of the designs that would fall under that heading.
It's just that you said quasi would go between RCT and controlled clinical study, and I didn't know there was a difference between.
Just go into controlled.
Yeah, I think it would be a subtype of a controlled clinical study, right? And some of the terminology, you can use the same terminology to, like different terminology to describe the same study design, right? There's not necessarily agreement on what to even call it, right? So I see. Oh, and I'm going to make my point here right now about randomized controlled trials. They're not called randomized control trials. I see this in papers. It's describing the type of trial. It's randomized, and it's controlled. Controlled means there's a comparison group or a control group. Okay, but it's not a randomized control trial. Like, I don't know what that is. And I even see it published sometimes. I'm like, what are you talking about? What is a control trial? Right? Anyway. So it's describing the trial. So in that case, it's People are randomized to treatment groups, and it's controlled because there's a comparison or a control, is what they call the group that you're comparing your new intervention to. Is the control. Randomized controlled trials. Yeah, and you see all sorts of different, what I was getting at is like the same study design, like a pre-post assessment intervention study could be called a whole bunch of different things. It's called a single cohort prospective study. It's the same thing, right? Single cohort is one group. Cohort is just a group of people who are similar, right? Single just means there's one of them. So a single cohort is like same as a one group. You know, and pre-post is like before and after some intervention. But you could say, you know, observational in that you're following people just as they're doing whatever they do, right? So there's lots of different words that actually describe the same thing. So what you want to focus on is not the lingo and the terminology, but what the actual design is. What are you doing, right? How many groups are there? What's your research design? And then understand where it falls here and what it's actually called, or because different disciplines also use different terminology, right? The epi-medical side uses different terminology than the behavioral psychology side that a lot of us are trained in. So it can be very confusing because they talk about controlled case cohorts and all this kind of stuff, case controlled, and we would call them something different but have the same methodology. So let's talk about these clinical trials then, so we can understand the different phases.
Clinical trials are research studies that involve people. Most clinical trials to test new cancer treatments are done in a series of steps called phases. If a new treatment is successful in one...
Oh, geez, I was just trying to turn on the volume. I don't know what happened there. No, I still can't turn on the volume.
Clinical trials are research studies that involve people. Most clinical trials to test new cancer treatments are done in a series of steps called phases. If a new treatment is successful in one phase, it moves to the next phase. Let's take a look at the three main phases of clinical trials. Phase 1 trials are small, enrolling less than 30 patients. Phase 1 trials are designed to find a safe dose of the new treatment, determine how the treatment should be given, and learn how it affects the body. If a safe dose is found, the new treatment goes to phase 2 testing. More patients are enrolled, usually 100 or less. Phase 2 trials study how the treatment affects the body and how the treatment works for a certain type of cancer. If a new treatment is found to be safe and to have some benefit, it goes to phase 3. This is when many participants are needed, usually more than 100 and sometimes thousands. Phase 3 trials compare the new treatment with the current treatment to see which one is better. One thing is certain with any phase trial. By taking part, you will help future patients by helping today's scientists learn more about cancer. For more information about clinical trials, including their possible risks and benefits for you, go to cancer.org.
Okay, I think that's all we need to know there. So that's obviously talking more about medical trials and drug trials, right? But we're going to, as we're listening to them talk about the different phases, we're going to think, how does that apply to the behavioral trials? So let's review it. So phase 1 is often called dose finding, right? And as I said, fewer than 30 people, looking at, is this thing safe, right? So again, thinking, what's your behavioral treatment that you're interested in? How much of it do they need, right? So in drug trials, it's usually what's the maximum tolerated dose. They just keep escalating it until something bad happens, right? So how much can we give a person? How much can they tolerate? And what's the best way to give it? So they do pharmacokinetics and pharmacodynamics. So if we give it in a pill, how long does it take to, you know, maximize the level in the blood? How quickly does it seem to impact symptoms? How quickly does it metabolize? Compared to if we give it as an injection or if we give it as an intramuscular or whatever, right? So safety dose delivery mode. Okay, so think, what does that mean in behavioral stuff? Phase 2, they often call proof of concept. So phase 1, you're really not looking to see if it impacts your outcome. You know, in most of these drug trials, the outcome is something to do with cancer progression, right? So do the cells die? Do they shrink? You know, do people have remissions, or do they ultimately, how long do they survive, So you're not asking those in phase 1 at all. In phase 2, it's when you start to look at your real outcome of interest, whatever it is. So maybe for us it's quality of life, or it's a symptom of fatigue, or it is stress levels, or maybe it's some biomarker or something, right? So phase 2 is where you're just looking for a signal. Is there a potential effect? And you want to see, is it even possible that this new treatment has any effect at all on the outcome that I'm interested in? And so the design here can vary, right? It's not a given it has to be an RCT. It can just be a single group and still be a phase 2 trial. So people get mixed up sometimes because they equate a phase with a methodology, right? The phase is really just about what are you trying to accomplish, and the methodology follows after. And that's a really good rule of thumb to keep in your mind is what's my research question? Because it's always, you're driven by your research question, not by some method. Like, oh, I should do an RCT, or I need to do this method. No, what do you want to know, right? So if you want to know, is this intervention safe? How much of this intervention is optimal? Then that's like a phase 1 question, right? If you want to know, is there a potential effect on the outcome I care about? That's a phase 2 question, or it's a phase 3 question. So phase 3 is more about efficacy, and phase 3 is when we only then that we begin to compare our new thing that we're developing with whatever is the next best thing, the gold standard, right? So in our circumstances, a lot of times there is no next best thing. We're looking at a sleep or something, and maybe it's a medication, but maybe usually patients just suffer with it, right? Or maybe it's something we're trying to enhance, like quality of life or post-traumatic growth, where nothing else has been developed. So sometimes in phase 3, then, you just want to compare with no treatment or usual care, it's often called, right? But maybe there is some standard treatment, like cognitive behavior therapy for depression would be your gold standard, or cognitive behavior therapy for insomnia, right, if that's what you're trying to target. And then you have some new intervention that you think might be better or as good as that. So that's your efficacy. And they talked about reducing bias and internal validity. Does everybody know internal versus external validity? And again, these are different, these terms have kind of morphed over the years, right? So what's another term for external validity?
Generalization.
Generalizability.
Generalize the findings to the wider population.
Yeah, and these days, the term they're using is more like scalability, right? Sort of, sustainability. So these are the kind of buzzwords now that are similar to, there's more emphasis now on that aspect of external validity, generalizability, scalability. It used to be all about efficacy and internal validity, right? Is can you prove causality? And that used to be all the focus is, what can I do to reduce bias, blind everybody, right? So that we know that the question we're answering is being answered in the best possible way. So lots of exclusion criteria, lots of inclusion criteria, homogeneous group. We want efficacy. We want to show that under ideal conditions, whether this new treatment is better, right? And so that was, for so many years, the emphasis was on internal control. And now it's beginning to shift, and I mean, that's why this program is actually called more pragmatic. It's another term, right, for more looking at generalizability, looking at external validity. There's sort of, the balance is beginning to shift a little bit, and so that's phase 4. No one used to care about phase 4. Scientists would do phase 3 and then they move on, right? Boring. Ugh. Who wants those messy studies, right? And it's totally true, because phase 4 is real world effectiveness. Okay, so we show efficacy, and people get efficacy and effectiveness mixed up because they're used often interchangeably. They're not used with precision for what their definitions actually are, right? But efficacy is an internal validity question, is efficacy. Effectiveness is looking at external validity, and they don't always one follow from the other. And that's been a big revelation in science, a big sort of, almost like a revolution really, is the gap between efficacy and effectiveness, because there's so many, they talk about valleys of death in translation of research findings. One of them is at the beginning and relates more to drug development and getting from the bench to the humans. But the other big valley of death is from phase 3 to phase 4, right? Or from efficacy to real world implementation. And I don't remember what the numbers are, but there's some shocking number of interventions that get tested and shown efficacious to some degree, and only like 4% or something like that are ever translated into the real world. It's crazy. So any questions or comments?
So what would be a good measure? Like, so let's say efficacy, we can, like, let's say we can measure like an effect size. What is a measure of effectiveness? Real world effectiveness is there?
A measure of effectiveness. Well, it depends what your outcome is. Like, do you want to look at uptake in the real world, or do you want to look? You can still look at effect sizes of outcomes, but you might have a different target that you want. So you would have, you know, say in your efficacy trial, you power it based on the effect size you think you're going to get in your controlled conditions, right? So you think that your new intervention is going to have a 0.5, like a medium-sized effect, you know, be clinically significantly better than the thing you're comparing it to. But then when you take that same intervention and you move into effectiveness, you're going to expect a much smaller effect size, right? And you might want to measure different outcomes too, right? That are more important in the real world. You know, so there's also this distinction between like population health-based interventions where you target way more people and they're less effective. Like in smoking cessation, this is the case. So if I do a 12-session behavioral smoking cessation intervention with someone, I'm going to have a 50% quit rate, something like that, right? That's actually a little lower. But if I try and do the same information over the internet and target, you know, a broad base of smokers, thousands of smokers, I'm only going to have a 5% success rate. But when you multiply the success rate by the number of people you're targeting, the broader intervention is actually better, right? Because in terms of population health effect, you know, so you're balancing off depth with breadth almost when you go from efficacy.
So can we say that effectiveness is efficacy that is generalizable? In different population settings?
Yeah, but then you can't use the word efficacy, because efficacy is very specifically referring to internal validity of a phase 3 trial. Yeah, pretty much. And it has to be randomized. So that's the only place the word efficacy should be used. It's used conversationally and sometimes scientifically to mean effectiveness, but it's not. It has a very specific definition. So I would use it sparingly. Oh, and here's another, just a diagram of the different phases. So it didn't talk about phase 0, but that's sort of preclinical studies when they're taking it from the bench. You know, they've been doing animal models and stuff like that. This is sort of preclinical stuff. And then phase 1 is safety, typically. And it's got timelines on this one, too. So it's a matter of weeks and tens of people. And then the phase 2, again, effectiveness at treating the disease. I don't know if effectiveness is the best word to use there. We would just talk about, often we just talk about, is there a signal? Is there any? I guess you could say effect. So months, maybe up to hundreds of people. Phase 3, see in this term it's using effectiveness, but that's actually not accurate. It's larger scale efficacy. And in phase 4, they're looking at, long-term safety and long-term effectiveness. So there's a lot of confusion about terminology. And again, across disciplines, people use words sometimes differently. And then I talked about study design options. So in phase 1, what's often done is it's done on an individual case. So each person gets the drug and they get this dose escalation, every couple of doses. That's often what's done in phase 1 drug trials. Again, we'll have to think in the behavioral phase 1 trial what we do. Phase 2 can be single group pre-post, or it can be a randomized trial, just depending on your intervention and where it's at. Phase 3 is almost always a randomized controlled trial. And I didn't talk about phase 4. I'm not sure why. Probably because we'll get to that later. Now we have a nice little video to hone in on those randomized controlled trials.
To conduct a randomized controlled trial, a statistician will select a sample size large enough to produce a significant result.
So we can talk about
Care
that
must be taken if the test subjects
are properly representative of the target population and not tainted by selection biases that might skew the results. The subjects are blinded, knowing as little as possible about what's being tested. They are randomly and blindly assigned to one or several groups. There may be a group that will receive the treatment being studied, a group receiving an established treatment, and always at least one control group receiving a control or placebo treatment. Test administrators are also blinded. This is called double blinding, such that they don't know what group each subject is assigned to, and whenever possible, they also don't know what the treatment is that they are administering. Everything is coded to avoid experiment or bias and to cancel out any effects like patients trying to respond the way they feel the experimenters want them to. The trial lasts long enough to satisfy the statisticians and the scientists. Finally, when the results are tabulated by a blinded statistician, this is called triple blinding, we get the results. The cloaks of anonymity are whisked aside, and we finally learn for a statistical certainty which treatments are effective and which are not.
This makes me smile whenever I listen to this. Okay, so let's watch it again. So I don't know if you're watching it and thinking about a drug trial, because that's what they were talking about, right? Let's watch it and think about your intervention or an intervention. Yeah, so think about exercise, think about yoga, think about Tai Chi, think about mindfulness or acupuncture, anything you might do, okay? And so we're taking this.
To conduct a randomized controlled trial,
we're trying
the
to do
statistician will select a
this
sample size large enough to produce a significant result. Care must be taken that the test subjects are properly representative of the target population
so
and not tainted by selection biases that might skew the results. The subjects are blinded, knowing as little as possible about what's being tested. They are randomly and blindly assigned to one or several groups. There may be a group that will receive the treatment being studied, a group receiving an established treatment, and always at least one control group receiving a control or placebo treatment. Test administrators are also blinded. This is called double blinding, such that they don't know what group each subject is assigned to, and whenever possible, they also don't know what the treatment is that they are administering. Everything is coded to avoid experiment or bias and to cancel out any effects like patients trying to respond the way they feel the experimenters want them to. The trial lasts long enough to satisfy the statisticians and the scientists. Finally, when the results are tabulated by a blinded statistician, this is called triple blinding, we get the results. The cloaks of anonymity are whisked aside, and we finally learn for a statistical certainty which treatments are effective and which are not.
Well, sounds good, eh? So where are the problems? I mean, obvious, right? What are some of the problems?
Like you can't like really blind participants to what they're doing if it's behavioral intervention. It's not just like a little pill. Like if you're asking somebody to do yoga, they know it's like the yoga intervention, right?
Yeah, and they know what they're doing, and they are doing it. And we never call them subjects. We call them participants, right? Because it's a much more collaborative process. They're the ones doing it. They have to do it, right? You know, that's part of the problem of behavioral trials is that it's a behavior, and no one can do a behavior for you. So it's very difficult, although it has been attempted, and I'll give you some examples maybe of how people have attempted to blind participants to what they're getting. And it's easier done, like, for example, in acupuncture than it is in, say, yoga, right? Although it has been done in yoga, believe it or not. Maybe misguided, right? And so what are some of the other methodological things that are hard to do?
Like blinding the researcher, like several times in behavioral trials, like the researcher is a big part of the participants, you know, taking him through the intervention. And here, like they want to blind the investigator from the treatment as well.
Yeah, and that can be done. Like you can have research assistants who do the assessments who don't know which group, like the post-assessment, say. So say our post-assessment is looking at walking speed or strength, right? And it's better if the person who does that doesn't know which group. So say we have the Tai Chi and Mindful, because if the person doing the assessment really wants Tai Chi to win, they can stop the stopwatch a little quicker, right? Even if they're not conscious of it, right? So, you know, there are things you can do in a behavioral trial. Can you blind the person providing the intervention? Here, do something. I'm not going to tell you what it is. You know, it's pretty much possible, right? If the instructor's teaching yoga, they know they're teaching yoga, you know. Yeah. So there's some real problems taking that model, which may work really well for drugs, and translating it to behavioral trials, which is in the dominant methodology and paradigm for how behavioral trials have developed. And that's why sometimes also when they're evaluated, the same criteria that's applied to the quality of RCTs in drug trials is applied to assess the quality of behavior trials, and they come up short, right? And I don't know if you've done it for, we did a big systematic review. Jill Johnson, actually, and one of my other postdocs, Jenny, were involved in a lot of the data extraction and scoring. You know, in the system we use, one of the points that you got was, were participants blinded? Right? And if they weren't, you lose a point. You lose a score. You get a worse score on the quality of your trial than if they were. Even when it's ridiculous, you know, and it has nothing to do with the real world. Anyway.
Certainty, anonymity are whisked aside, and we finally learn.
So, and if we look at the match study, which is also preference-based trial, and that's been designed by us. But if you ask if you tell the participants upfront during the screening process that it's a, you know, we'd like to randomize you, but we also give you preference. Like, you know, depending on your preference, you can choose the program. So there are some people who want to do Tai Chi, but their physical health doesn't allow them to do that, so they'll automatically choose mindfulness over Tai Chi. So that's one other problem, I guess, which is...
Well, it's a problem and it's not a problem, right? I mean, the reason we designed that trial, and again, we'll talk about this more, is because we found out in a previous trial that preference matters, and if you're randomized into a group you don't want, you're not going to do as well, right? And so that calls into the question the whole methodology of randomization, which is considered, you know, not only the gold standard, but here, I'll give you another video on it. So this woman is going to explain to you, in the previous thing they didn't really talk about, 2 videos ago with clinical trials, they didn't talk about the randomized controlled trial. The last one talked about it. This one is interesting because she talks about, I think there's a man in here too, about what's the big deal about randomization, right? What's the big deal? Why not let people choose their interventions? You know, and some research we've done, we've compared people who sign up for a healing arts program and people who sign up for a mindfulness program. And we get them both to do the same questionnaires before and the same questionnaires after. Well, what's wrong with that? Right? Well, we didn't randomize, so what? Well, she does a good job describing it, so I'll play it.
Clinical trials are a fundamental part of clinical research.
They genuinely are experiments. You think you know the answer, but very often you don't.
A clinical trial is aimed at comparing a new treatment against the best available current standard treatment. What we're trying to do is to see whether the new treatment is safe and effective. Clinical trials can be done in a variety of settings, in hospitals, in communities, in doctors' surgeries, and are essential before we judge whether a new treatment is worth introducing for routine clinical practice. A randomized controlled trial is a specific type of clinical trial, and the aim of the randomized trial is to reliably say whether the new treatment is better than the old or the standard treatment. A group of individuals are randomly allocated to either the new treatment or the best current standard to compare those 2 groups of individuals to see which treatment is best.
A randomized controlled trial involves first and foremost the process of randomization, which is when you use chance to determine which group people are allocated. Now, nowadays, chance is really done by the generation of computer lists. And the controlled part of the randomized controlled trial refers to your comparison, your standard group. In some cases, if you're talking about development of a new treatment or a new area for treatment, that standard could be no treatment at all, or something we call a placebo, a dummy treatment, which would be to mirror the treatment that you were interested in.
So if treatments are assigned at random, we will make sure that the mix of patients which are assigned to one treatment is very similar to the mix of patients which are assigned to another treatment. So they will be similar in their ages, in the sex distribution, in the stage of the disease they're in, and so that we'll be making a fair comparison between the two treatments in this way.
Of all the ways that we can think of comparing a new versus a standard, randomization is the best way we can make that comparison. And in fact, it's the only reliable way in which we can make that comparison.
If you did not have the ability to randomise and doctors were allowed to choose who they gave the treatment to, the new exciting treatment, which could well be better, they might choose to give it to all the older people who are heavy smokers. And then all the young people who are non-smokers get the standard treatment. And I think then we'd probably get the wrong message from that trial, because we might think the new treatment wasn't very good, but really it's the older age and the smoking that has made the difference. Now, age and smoking, of course, you can measure, but the trouble is there are many things in life that you can't measure that might have an impact on the disease, and that's why we rely on randomisation to make sure those other things are evenly distributed between the groups.
I'm a passionate believer in clinical trials. I believe that it's the best way of testing a new treatment idea. It is the gold standard. It also means that patients in a clinical trial will, at an absolute minimum, receive the best possible standard treatment.
As a clinician, I think it's really important to be involved in clinical trials because it's opportunities for your patients to be at the forefront or have access to.
I think the rest of that's a lot of blah, blah, blah. But what's important to me in that is that randomization controls for all the things you can measure, but more importantly, all the things you could never measure or wouldn't even think about, right? So if you think about the study where we took all the people who enrolled in healing arts, they're all cancer patients, we took all the people who enrolled mindfulness, we compared them before and after, but they weren't randomly assigned, right? So what else could be different? I mean, they were similar on the things we could measure. Similar mix of males and females, similar age, similar cancer distribution, right? But what else could influence how they respond to these treatments differently?
Motivation to take up that treatment?
Sure, motivation, what else? Let me make it easier. Say we're comparing exercise to mindfulness. How are the people who choose exercise maybe different to start out with than the people who choose mindfulness?
Physical limitations.
Sure, they're physical, and maybe you could measure that. And you could control for it, you could adjust, you could match people. What are other ways they might be different?
The belief in the success of the treatment there?
Yeah, their expectancy. So that's another thing that, another lecture is what in the world is the placebo effect anyway? Right? And how is that important in behavioral trials? You know, so when you say expectancy, that's what I call placebo effect, right? Because you give someone a pill, they think it's going to help them, it helps them. It's because they expected it will, right? It's a big deal, and it's an even bigger deal in behavioral trials when a lot of the reason people improve might just be because of that anyway, right? It's very hard to tease apart. I don't know, there could be different personality characteristics of people who choose an exercise, an active intervention versus a mindfulness. Maybe they have different spiritual beliefs. How else could they be different?
Support from their friends and family, so they might have a family that's very active already.
Yeah, sure. I mean, they could, yeah, I mean, there's so many different ways they could be different, right? They could be different in their belief systems, you know, different religions. It could be, well, I mean, there's just millions of ways people could be different, and any of those differences could impact how they respond to an intervention, right? So really, the only way to have a level playing field at the beginning, when people start, to know that your groups really, really are basically the same, is to randomize and have a large enough sample, hoping that everything will even out, right? So you basically, it's just one group of people. They all sign up for the study. They're all willing to do either treatment. Say there's two, right? They know they're going to get mindfulness or Tai Chi. They know they're going to get exercise or yoga or whatever. They know what they're going to get. They're willing to take either one. So it's one group of people, right? They've got this mix of characteristics. You randomly split them into two. They should be equal, right? You should be starting with the same baseline, The only way to assure that is to randomize people from one group. There's no other way to have an equivalent baseline. You cannot statistically control. And using the term control is actually inaccurate. You can adjust certain things statistically, but it's not the same as having matched groups and then randomized groups. And alternative to that is people try to match, right? They say, okay, here's somebody who took my chronic healing group that I want to study, and it's a woman with breast cancer who's 52 who chose not to take the chronic healing, and I'll monitor her over time and see if their changes are different. And then I'll say, well, this woman improved more in her quality of life, it must be the chronic healing, right? Well, no, you can't say that. So even though you match them on a couple of things, there's a million other things that could be going on that are different between those two women, right? So it's a poor substitute, you know, if you really want to answer efficacy, and efficacy is about causality. So the randomized design is the only design, maybe, that can answer the question of causality, right? So the only difference between these two groups of people is that one group did the intervention over 8 weeks or whatever, and the other group did not. Supposedly, that's the only difference, right? And so any difference in outcome, you can causally attribute to that difference.
Because they were all the same at baseline.
All the same at baseline, supposedly. And that's why statisticians hate it when researchers do t-tests and chi-squared tests on baseline characteristics in a randomized controlled trial, because they're not going to be different. If you design your trial properly, they will not be different, and you do not need to check them, right? So it's kind of overkill when people do it. So let's see, how are we doing for time? So the question is, what about behavioral trials? So that was it for material for today. So let's just maybe talk a bit about this. So what would a behavioral trial look like in phase 1? Like what's phase 1 about?
So how many sessions do they actually need? For the
Yeah, how many sessions is one question, right? But what's even more basic?
What's the content of that intervention?
Yeah, I mean, what's the problem, right? Like, go right back to the beginning. What's the problem? So give a problem. Let's use an example. What's the problem that our patients might be encountering?
Fatigue.
Okay, so say fatigue's the problem. Okay, so not only what's the dose, but what's the treatment? What's the drug, right? And how would we figure that out? You could look at previous evidence. So what have other studies done to try and treat fatigue? Similar people? Yeah. What else would you ask yourself?
I guess like delivery method too, like.
Delivery method of what though?
It depends on what you're using, I guess. But if it's like an intervention, maybe it has to be in person, or if you're gonna do it online or whatever.
Yeah, but back up a bit though.
You can measure the outcome.
Yeah, so if fatigue is your outcome, that's a good question, right? What even is fatigue and how do we measure it, right? That's defining the problem, right? And for some things, like fatigue is a good example, there's no consensus on how to even measure it, because it's not something, you know, you can get in someone's blood sample, right? They have to tell you how they feel. Okay, so what is the outcome and what's the best way to quantify that? That's definitely a question.
Something like New York Heart Association criteria, you know, how long they can walk for before they start feeling breathless, or they can walk on flat surface, or they can climb the steps.
So that could be an outcome, or that would be an inclusion criteria?
If you're sort of categorizing people on different fatigue levels.
Yeah, so for example, if you want a study of cancer-related fatigue, there's a definition of that and a way to assess if someone meets that criteria. But then you also need your outcome, right? So how are you going to measure improvement in your trial?
Outcome, if a person is just initially able to walk on a flat surface, so then after the intervention is able to climb up the steps. So that would be an improvement.
Mm-hmm.
So that's one way of quantifying whether the fatigue level has reduced in a particular patient.
Yeah, so I mean that's one thing you have to think about. So before you even get to the intervention, you've got to think about what's the problem and how do we assess the problem, right? How are we going to know if the problem's even improved? But then when it comes time to developing the intervention, so say you've said your problem is fatigue, we know how to measure it, we know who has it. How are we going to come up with some behavioral intervention, what elements is it going to have? Like, how do we do that? Where do we start? Before we even get to dose, right?
If there was nothing in the population of interest, and there was nothing, imagine there was nothing in cancer survivors, you might look at the same symptom being rated in another clinical condition where they've developed an intervention that might be applicable there. You could do that.
Yeah, and definitely you don't want to reinvent the wheel, right? So in our case, there's always a little something out there, right? So you might look for systematic reviews or meta-analyses or even randomized controlled trials, or maybe there hasn't been a randomized controlled trial of any intervention, so maybe you need to go look at case reports and qualitative research. Maybe you have to talk to patients about, what makes your fatigue feel better, right? So then you come up with, okay, exercise seems most promising, right? And then what do you do? So we're still in phase 1. We're still, what's our intervention, right? Like you can spend a lot of time in phase 1. And people probably don't spend enough time in phase 1, typically.
If you start to do these things like trying to find, let's say, the right dose, right duration, etc., would you be doing like really small groups, like trying it out with like 3 people at a time, or get the same group of people and then like, okay, this week do it for 40 minutes a day, and then this week, okay, try just 20 minutes a day? Like, how would you even go about that?
It's a good question, right? There's different ways you could go about it. Like you're talking about kind of like a crossover design with the same subjects, which would be, this week try this type of intervention, take a week off and then try a different thing or a different duration maybe. You could also have 2 groups of people where, say, your question is about duration of exercise or meditation. We think maybe 20 minutes is enough, but other people have done, 30 minutes. So you could have 2 groups of people and everything else being equal. Half of them does, randomly assigned, half of them do 20 minutes, half of them do 30 minutes, and then you look to see if the outcomes are the same or different. That's one way to do it.
You do so many studies this way.
You would have to do 1 million studies.
Yeah. At what point is it enough?
Yeah, well, that's a good question, right? So we'll talk about, there's designs that can tackle a few of these issues all at once. Yeah, one's like the most designed. So those are some examples. What are some other examples of phase 1 types of behavioral trials you might, or questions you might look at?
The timing of, like, when should the intervention be, morning, afternoon, evening, or just before the fatigue, or just before chemotherapy or after chemotherapy?
Yeah, I mean, there's lots of questions around timing. So if you think about the medical thing, they've already pretty much decided when they want to do it, I guess, typically with drugs. But we may not know that. In exercise research, it's a good example where some people have tried doing it during treatment, right, or just after treatment. So when is the ideal timing, right, and what's the ideal dose, right? So how much do you need to do at one session? What else?
Duration of the intervention. So you might have a 12-week intervention, but you do some analyses planned at 6 weeks, so you can see if the improvement was actually made in the first 6 weeks. You don't have to do that.
Yeah, or maybe you do it every week.
Yeah.
Right. So other people have done 12 weeks and just done before and after. Say you get them to fill out a questionnaire every week, you could map the graph of how quickly people change, right? That would be a good idea. Yeah, and then that would actually help you find dose. And then what about these multi-component interventions, like the mindfulness thing? It's got the yoga, it's got the mindfulness, it's got the, the group discussion, it's got all these different elements. Like how do you, if you're starting from scratch, how do you build a multimodal intervention, right? It's like, you think about it, it's way more complicated than a drug, right?
Yeah.
And then control groups too. So phase 2, that's more your proof of concept. So what would you do there?
We'll just look at previous studies to see whether this intervention has actually worked on this type of outcome that we're trying to improve. So there's some sort of evidence. Like, as you said, not reinventing the wheel. We're not the first one saying that yoga or mindfulness will actually improve the health outcome.
Right. So you might actually not need to do phase 1 or phase 2 if someone else has already done it. Right, but often you'll go back and you'll see phase 2, phase 3, but there's no real phase 1. Like there's no, real careful, systematic rationale for how they put together their intervention. They just took someone else's, maybe that's a good rationale, or, and they just started testing it, right? So you get to this point where there's phase 2, phase 3 evidence, but people are starting to question. So say even in mindfulness-based stress reduction, right? It is the way it is because it's always been that way, right? John Kabat-Zinn just said, okay, let's do an 8-week intervention. And then people started testing it. It's like, okay, we know that this 8-week intervention works, but like, do we know, which, these questions come up all the time. Well, what's a minimal effective dose, right? Are we overdosing people, right? And taxing the system, making them pay more and do more stuff? Do we need all these different components, which are the active ingredients, right? So to go back and dismantle and figure all that out isn't very efficient. Like maybe someone should have done that at the beginning, right? If they've been thinking this way, maybe they would have. And then when you get into phase control group, so it's your, comparing it to your next best treatment, and maybe a placebo, right, or some other control condition. Well, what is that in a behavioral trial?
Like comparing the effectiveness of 2 behavioral interventions, like what we do.
Yeah. But there's also
or a sham behavioral intervention.
Could do that. Is that ethical?
Perhaps.
But how else we get to know causality?
Yeah, well, you also have to ask yourself what's in it for the patient, right? It's like if you were a patient, and not only what's in it for them, like, is it ethical? Why would they even want to be in your trial, right? And, like, is it feasible? Like, are they actually going to sign up? Like, there was, after a while of doing mindfulness research, Laura LaBelle wanted to do her PhD and do a randomized trial of a waitlist trial. So have some people start the program immediately and fill out questionnaires. She was looking at mechanisms. So at the beginning, halfway through, and at the end, and she wanted a control group of randomized people who were waiting for the next program to do the same timing, right? But when they signed up for the study, they were on the wait list for the program, but when they were randomized to this second group, they just dropped out and took the first one. Because they're like, well, I want to take the program now. And she'd be like, well, you can't be in my study because you've been randomized to the wait list. And I'd be like, well, I won't be in your study then. Right? So she could not recruit people who were willing to be randomized to wait list in a situation where they wanted the group and it was available for them clinically. Otherwise, right, in some circumstances, the only way they can get the intervention is to be in the research and wait it out. Right? But for us in that circumstance, they were just like, nope, sorry. So we had to do a natural wait list, right, which is the program goes every 4 months. Once it's started, people get their name on the list and they have to wait till the next program. So if there was more than 8 weeks of waiting, she could get them to fill out the questionnaires while they were actually waiting, right? So it was the same design and the same time points, but the people in her wait list, it wasn't randomized. So that's, a big hit, a big sort of black mark on your study, right? 'Cause it's not randomized. So you have to look at what's practical, right? And often what's practical is not what's perfect for determining your efficacy in your study design, right? Yeah, maybe it's not ethical to offer patients an intervention that or you designed to be ineffective, right?
Is it like really difficult to find a set of people who, after knowing that there's an intervention going on, would like to just carry on with their regular stuff, regular way of living, and then they could be a control? Is it like really hard?
Oh yeah, that's why we never do no treatment controls. It's always a wait list because these are clinical populations who want the thing.
Yeah.
They want acupuncture. They may be willing to wait, but they're not willing to forego it, right?
I feel like with a waitlist control, this is like a thought that's just floating around in my head, but like with a waitlist control, it would also be tough if you were using participants who were like actively being treated for cancer, because that almost ensures that your second group is always going to be further along in their cancer trajectory than your first group, which means you've got people who are newly diagnosed, depending on how long your
waitlist is, and depending on how.
Yeah, which doesn't really matter because the measures you're interested in your control group are the ones taken while they're waiting,
Right.
right?
Yeah.
You're not that interested in their later response to the group, although it would be nice to be able to up your sample size by doing that. But what you're interested in is the baseline,
Yeah.
like say they're getting treatment, right? And it will be the same time point. So they're starting treatment.
Right.
This group gets the intervention. This group's waiting. 6 weeks, 8 weeks. So they are at matched paces in terms of what their treatment is. But yeah, then this group goes on to get the intervention. So comparing the response to the intervention of these guys and these guys is apples and oranges. You're right.
And this concept of waitlisting also solves one of the ethical issues regarding RCTs, that the control group also gets to do the intervention, which has been sort of, there's an evidence the intervention works, it does something good for people involved.
Yeah.
So they might ask like, okay, what's in it people who are in the control arm? It's like eventually they also get the intervention.
Yeah, and we know, like, because the line of research we do is so far developed, we know that it's efficacious, right? So you can't not give it to people.
Yeah.
You can't give them usual care because that's not standard treatment, really shouldn't be standard treatment anymore. But there's downsides to a wait list too. Can anyone think about, so imagine, there's the person in the wait list, they're waiting, and so they're filling out these questionnaires. These guys have done their intervention, they're done, these guys are about to start, and these are the measures we're comparing, right? So what's going on psychologically for these guys compared to these guys in relation to the intervention that might affect their measures?
So
Like positive anticipation of like what's about to happen.
Yeah. Finally, the wait's over, and I'm filling out my questionnaires, right, where I'm supposed to still be feeling rotten because I haven't had anything. But I'm excited because I'm. So often you see the wait list improving too, which may be because of passage of time, right? We're often looking at cancer survivors who are recovering from all sorts of symptoms, but it could be also exacerbated or enhanced in waitlist controlled trials because the waitlist is just about to start. Finally, the anticipated intervention that they wanted, right? And these guys, well, they're done. Oh, it's kind of disappointing. They feel bad, right? So it may actually make your effect size between groups look smaller, and it does when you show the graphs. Almost always the control group is improving a little bit, and the intervention group usually more. Yeah.
And is there, how much of a risk is there of people trying to find other ways to manage their symptoms in the meantime?
It's called contamination.
Yeah, because like if they're waiting for the mindfulness group, so they'll tell them, okay, don't do meditation for the next 8 weeks, but then maybe they're going to be doing other things to try to help.
Like go get some Reiki or something, right? Like,
Yeah.
Yeah, so we measure it. We measure and we call it contamination. It's very hard to control for in your statistical analysis, but we typically have that data that we could look at, right? If it was like half of them who did something, then you'd have to find a way to.
How do you measure it? What's an example of measuring?
We just have people fill out surveys typically. So in their post-assessment, it would be like, have you done any of the following over the last 8 weeks? I've gone to see a therapist, gone to yoga class, and anything else, and they write it in.
Yeah.
And so then you could quantify that into some variable that you might use in your analysis, or you could take those people and divide them into subgroups or something like that, right? Yeah. But you should always measure it because there is always a risk of that when it's behavioral intervention that people, and they sign up for the study because they're interested in this thing and they want it, right? Yeah, so sometimes if they're assigned to wait or to not get it at all, they'll just get something else, or they'll get it outside.
And it might also increase the dropout rate, so they will be tired of waiting or something unexpected.
Well, if the wait's too long, they
so
might just scrap it. And you'll see differential dropout across conditions.
And we've seen this in the math study recently, like in my last 2 months of experience. Like there was one lady who said like something unexpected has happened in her family. So although she had sort of she wanted to do it, but now she's unable to do it. So if she had included her in the immediate group, she would have done the program already. But now something unexpected has happened that doesn't allow her to participate anymore. So even if she wants to, it might just increase the dropout rate.
Yeah, and having longer waiting periods. So say you want to do a bit of follow-up before you let the wait list do it, because that's an issue too, right? You often want to do follow-up to see if the effects of your intervention are of long duration. But if you want to compare them to a control group, they got to wait that long too, 6 months, 12 months, and they may not be willing, right? And you might lose them. So you have to balance, like, oh, it'd be great to have long-term follow-up with the 2 groups, but eventually your wait list is gonna give up the ghost. They want the intervention.
Which is why, sort of, in one of our previous meetings, we came up with this plan of offering gift cards to waitlist people or people who are following up on their 3 months and 6 month assessments. So I think we're going to introduce this thing as an amendment in
Yeah,
ethics
we
application.
should do that.
Initially we didn't plan, and we are still not giving it the baseline assessment, any incentives, but we are giving this sort of incentive for follow-up assessment so that people still keep on track, still go for their follow-up assessments at 3 months and 6 months when there isn't enough motivation for them to do so.
Yeah,
so
and
we've done the program.
Ethically, your incentive can't be too big, or it's considered
It can't be
coercive.
coercive, but it can be like just a small motivation sort of thing. Oh yeah, have a free parking.
All right, well, our time's up. Next class, look at this exciting stuff. So behavioral clinical trials design. So I'm going to give some examples. So we started talking about waitlist trials and stuff like that. Yeah, and I haven't built the class yet, but I was going to give you some readings of specific studies that illustrate these different things. So if there's anything else on your wish list for next time, tell me now. All right, so we'll see you then. And I guess we'll have this recording hopefully up on D2L, but that's probably more of interest to the people who aren't here. Thank you. Yeah, and if you have any feedback for me, I'd be happy to hear it.
Linda, did you want so I recorded it and then I also have an audio. Did you want both up or just one?
Well, why don't you